Buenas and Hafa-day. I am Senator Sabrina Salas Matanane, Chairperson of the Committee on Health and Veterans Affairs. This public hearing is now called to order. The time is 2 o'clock, and today is Tuesday, May 13th, 2025. Thank you for joining us in person, at home, and online for this public hearing on documents number 38GL-25-0442 and 38GL-25-0443, GMH new fee packages respectively, and bill number 2438 COR introduced by Senator Will Parkinson relative to emergency contraception for survivors of rape, as well as bill number 76-38 COR introduced by Speaker Frank Blas Jr. relative to emergency care immunity from liability. Notice of this hearing was provided to senators, stakeholders, and the local media on May 6, 2025 and May 9, 2025, thus meeting the requirements of the open government law. In addition, notice of this hearing was also posted on the Guam Legislature's website and the Guam Public Notice Portal. Bless you. Materials for this hearing were shared in the committee drive and are available for print upon request. Recording of today's hearing will also be available online via the Guam Legislature's media on YouTube. I sincerely appreciate the presence of my colleagues, stakeholders, and members of the public who have taken the time to engage in this legislative process. Today's hearing is an opportunity to receive input, examine the impact of the proposed legislation, and promote transparency and accountability in the legislative process. Each senator will be allotted 5 minutes to speak. Bill authors will be given 10 minutes to present and summarize their proposed legislation. These time limits are in place to maintain an organized and productive discussion while allowing for broad participation. I urge all speakers to be concise and respectful of the time so that we can hear from as many voices as possible. I would like to acknowledge and recognize the committee members and senators that are with us today, Senator Therese Terlahi and Senator Will Parkinson. At this time, I invite members of the Guam Memorial Hospital Authority's executive team to present their resolutions for documents number 38GL-25-0442, as well as document number 38GL-25-0443, the new fee packages for GMH. If you could speak closely into the microphone, be concise, and state your name and title for the record, beginning to my right.
Good afternoon. My name is Dr. Kwasi Yame from Neurosurgery, Chief Medical Officer of GMH Hospital.
Good afternoon, Senator Saidi Taisakan, General Accounting Supervisor for Revenue Cycle Management.
Good afternoon, Yuka Hechanova, Chief Financial Officer, Guam Memorial Hospital.
Jordan Paulion, Legal Counsel for Guam Memorial Hospital.
Thank you. And we can begin with document number 38GL-25-0442, the new fee package dated December 20th, 2024, and then we can proceed into the next one.
We had a public hearing on the fees, which we do every quarter. And so this is the one from December. So of course we support it. But we are here to answer any questions. The fees can be all different kinds of things, mostly for supplies. Whenever we order a new supply that's requested by the servicing department. For example, if pharmacy is ordering some kind of new medication, they will request from us to create a charge code. And then we compile all these charge codes and have our quarterly hearing on it, where all the insurance providers are all invited to submit testimony. And then it is passed through a resolution through our Board of Trustees at the next meeting. So we're here and available to answer any questions you have.
Okay, and that's the same, I guess you would say, for document number 38GL-25-044?
Yes, ma'am.
3.
Yes.
Okay. I guess then we can open it up for questions. Senator Terlahi, did you have any questions regarding these documents?
Yes, for the December. All right, so in for the December fee package, Staywell and Calvo's objected to a certain code, the same code. They said that according to correct coding guidelines, the hospital should not bill this code in conjunction with a professional fee. Apparently, it's a facility component charge for outpatient clinic visits. And it's the first time it's being implemented. The hospital has, according to Select Care, the hospital has to select one of the two fees. He notes that many of the professional fees are significantly higher than those charged by other contracted hospitals in the area, as well as the fees reimbursed to hospitals in Hawaii and California. Staywell, Mr. Mendiola said, charging bill payers for the first time, despite already billing a professional fee component for the same visit. This is not a standard practice in Guam, and Staywell does not reimburse this code separately. This code reflects a 54% cost escalation in comparison to MCS Medicare reimbursement. GMH rates are already higher, and adding the new code would further increase costs, and this will escalate healthcare costs for the community. Can you please speak to that code? And but it looks like the Board of Trustees approved the code despite the objections. And could you speak to that?
Yes, the code is specifically, it's a CPT code G0463, and that is the facility component of the outpatient visits that we have in the hospital. So we normally charge the professional fee, but we've never charged a facility fee. And the staff had researched that this was something that we could charge since we have the clinics on site in the hospital. So we did establish the fee, and we did get the feedback from Staywell and Select Care, and we did respond that we also found some other hospitals in the mainland that do charge this facility fee, and because we are a hospital, we are allowed to charge the fee.
All right. They say this is higher than the fees reimbursed to hospitals in Hawaii and California.
He's probably alluding to the fact that we use the physician's fee reference as our guide for professional fees. It is not the same as the Medicare physician fee schedule, which is a lot lower.
All right. So I guess that's my next question is the 99 new fees, do they mirror national rates, or are the rates purely determined by GMH?
For supplies, and that is based on the actual cost. So we have the purchase order and the amount that we're paying for the certain supply or medication, and then it is marked up by I can't remember. Based on our net revenue model, we mark it up a certain percentage, but we cannot go over $500 above the cost of the item. Oh, they're the 5%. Yeah, so we do mark it up, but we cannot, there's a capitation, so we're limited to raising it no more than $500 over the cost. But for the professional fees, we use the physician fee reference, like I mentioned earlier. For other facility fees, we use the Medicare rate.
And what about for the facility fees?
Yes, and the facility fees, we use the Medicare rate.
Medicare rate?
Yeah, if it's a new fee.
All right. So there was a 3-month gap between the December hearing and the board's resolution approving the December fees. They approved it in March. Is there a reason for that gap?
Because we wanted to thoroughly research the concerns of the two insurance letters they sent to us, and so we wanted to really take the time to make sure that their concerns were valid and how we could best respond to their concerns. And so we waited, and then of course the board doesn't meet until the end of the month, And before the resolution goes to the board, it also has to go through the Finance and Audit Subcommittee, which meets in the middle of the month. So sometimes the timing of the resolution, passage of the resolution was off by about a month or so. But we did want to take the time to address their concerns.
All right. They say they will not cover this fee since it is already a professional fee charge. What are you going to do if they don't pay it?
You should answer that.
So we've been appealing with the insurance for the G0463. We've been mentioning to them that G0463 is a facilities charges for an outpatient within the hospital. For so many years, G0463 was not charged to the insurance, and insurance were not reimbursing that to any healthcare because during that time we only have Guam Memorial Hospital. And some of the clinic was using just the professional fee. Then when we created the outpatient clinic and this G0463, we informed them that this is the facility counterpart of professional fee in a hospital setting. So they're still like challenging GMHA that no, because this charges is already inclusive on the professional fee. But as what Ms. Shuka mentioned earlier, we're using the PFR on charging the professional fee, and G0463 is Medicare.
And what happens if they don't pay, like they've threatened?
I'll answer that. There is an appeal process that we go through, and that's what we've instituted is first it's handled informally where we discuss it, why they won't pay it, and then it does eventually get escalated to legal.
All right. Thank you. Thank you, Madam Chair. That's my only concern on this bill is that objection by the two insurance companies.
Thank you, Senator Terlahi. I'd also like to recognize the presence of the Vice Chair of the Committee on Health, Senator and Vice Speaker Tony Atta. Senator Will Parkinson, do you have any questions?
No, it's okay, ma'am.
Thank you, Senator Parkinson. Vice Chair, any questions? Okay. All right, thank you, GMH, Jordan, Yuka, RCM, I'm sorry I didn't get your name.
Saidi Taisakan.
Tysigan, Ms. Tysigan, thank you. And Dr. Quasi. Thank you again. We will now proceed with testimony on Bill 2438, authored by Senator Will Parkinson. Oh, we were taking. I'm sorry, can we call back up GMH? We do have further questions from Senator Terlahi on the March fee schedule.
Yes, sorry. Okay, so regarding March, that was mainly the issues that were brought up was regarding what you described earlier, the physician fee reference being used by GMH for physician fees versus the Medicare physician fee schedule. So by what authority do you use the PFR? Is that a statute?
It was passed by the GMHA Board of Trustees back in 1997. That was the model that was approved to be used for the physicians' fees.
And you're allowed to do that versus following the Medicare rates?
Yes, because it's an alternative. We can follow the Medicare rates, but it would have to be approved by the board, and the Medicare rates are significantly lower than the PFR. We do want to initiate a study just to see, like, from 1997, and here we are now at 2025, to see what the, I guess, the financial impact would be if we did switch to the Medicare rates.
All right, and so how long have you been using the physician fee reference versus the Medicare rates for physicians? Because you use the Medicare rates for all new fees.
For the facility fees, because we don't have any other way of determining the facility fee. For the supplies, it's based on the cost of the supply, and then for the physician's fee, it's the PFR, as it's dictated by a board resolution for us.
How long have you been using that? Since
1997.
They've been charging physician fees higher than Medicare rates for all this time?
I don't know if it was higher at that time, but recently, because I've compared the two in the last few years, and yes, the PFR is much higher than the Medicare rate.
Because that's what the insurance companies are complaining about. That
Yes.
the PFR that GMH is using is higher than Medicare, probably higher than other hospitals you're saying. Do other hospitals use their own scale of physician fees, or do they all follow Medicare rates?
They can use, the nice thing about the Medicare rates and the PFR is they're already established. We don't have to do any kind of studies. They're already established and widely accepted. For us, it would mean changing and convincing our board to do so if we wanted to change to the Medicare professional fee schedule.
But what do other hospitals do?
I think most of them use a Medicare rate, but not at that flat rate. It's at the Medicare rate times 100, 200%, just depending on what they negotiate with their insurance carriers.
All right. Is this physician fee schedule that you're using the reason why in the last hearing you told us they're refusing to pay certain things because they're saying you're charging fees for physicians that are in outpatient clinics, something like that?
Yes, but that doesn't have to do with the fee schedule. It had to do with contractual arrangements that we have with our physicians and the contractual arrangements that the insurance companies have with those same physicians.
So by passing these fees, do we affect that controversy?
No, because it didn't have to do with the fees. It had to do more with, we have a contract.
Double billing?
We have a contract with the physician, and so we bill their claims. And yeah, I guess they might be concerned that there's a double billing, but if we bill for the claim, it's because that patient fee belongs to GMHA. If the physician sees the patient in his clinic, then they will bill their own fee from the clinic.
Right. So is there something we should do when we are allowing these fees to go through to resolve that issue?
Not that I can think of, because it's really contractual.
It's a contractual issue, and to the extent the Board of Trustees has created the fee, it'll be negotiation and discussions with the insurance companies to resolve it, whether it's on the fee schedule or, whether it gets, irrespective of where it is on the fee schedule or what the rate is, the process for resolving the claims that already exist are going to be through direct negotiation with the payors as opposed to adjusting the fee schedule. Though, anybody's free to petition the Board of Trustees to amend the fee schedule at any time as well.
All right. So when you negotiate with the different companies, is it possible they're going to end up with different physician fee rates?
It's possible, but we would have to change. The resolution or amend it so that the Board of Trustees will authorize us to use a Medicare rate. Because right now they're telling us to use a PFR.
So when you negotiate with the insurance company, you can't change that? You said you're also going to negotiate the rates.
I don't think we're going to negotiate the rates. We're trying to negotiate the payment of our rates through the contractual terms that are already in place to resolve any disputes over that facility fee charge and the professional fee charges. So that's an ongoing discussion with a couple of the insurance companies. Most of the insurance companies, though, are paying those. It's just a couple of examples that have raised some specific objections with it.
All right. And are these fees in any way related to the non-payment of the $1.6 million that you testified was due from one insurance company? Is it because of this issue?
That payment issue has to do with them for denying the charges for the outpatient, the clinics, which we are still appealing.
Which sounds like this issue.
It is part of that total. There are a couple other denials that they've started denying claims for, such as the IV infusion administration, within the hospital setting and other things. So that, and then some of it is just unprocessed. Some of that $1.6 million is also just unprocessed or delayed claims as well. The total outstanding, I think, from the outpatient clinic right now in pending claims is about $400,000. And that does not necessarily at this point take into account what the patient responsibility would be.
All right, so I'm just concerned again, Madam Chair, that we've got 3 insurance companies concerned with this fee. It's involved in the litigation or the non-payment, and it's involved in the denial of claims now that have resulted in, I guess, a testimony we received at that last oversight. So I don't know. All right, but thank you very much. Thank you for your testimony.
Thank you, Senator Terlahi. I'd also like to recognize the presence of Senator Tello Taitigui. Senator Taitigui, we are still on the new fee charges. We're now on the March charges. If you had any questions for the panel. Okay.
I just have one. I've been listening on the way over here. I apologize, Madam Chair, for being late, but I was listening. There was something that you made a comment, Yuka, when Senator Terlahi asked you about if the physicians are charging the Medicare costs, and then you said yes, they're charging that, but with 100%. What exactly did you mean?
I was explaining that in other hospitals, they usually negotiate the physician fees based on the Medicare rates, but usually marked up maybe 100% or 200% of Medicare rates.
Wow. Okay, and that's what they do. I mean, yeah, that was like in other jurisdictions. Guam, do they do the same here?
We don't use the Medicare rate for the physician's fees. Okay. We use the PFR, which is the physician fee reference, which is another publication of physician rates.
And is that higher than the Medicare?
It is higher.
About 100% higher? Is that why you get? They don't use the Medicare?
It varies. Actually, some fees are less than the Medicare rate, and some are higher. Some are double. Some are maybe 50%. It just depends on how they calculated it. But it is generally higher.
The PFR is higher.
Yes.
Okay. Is there a reason why you decided to go with the PFR instead of using what other jurisdictions uses?
It was authorized since 1997 by the Board of Trustees, so that's been what we've been using ever since.
And it can be revisited, though. I mean, do you find it an advantage for the people to actually have it at the PFR versus the Medicare rates?
It wouldn't impact the quality of care. It would really be completely a reimbursement issue.
Okay, thank you. Thank you, Madam. Wait. Does GMRC charge facility rates?
GRMC does have, I think they charge it a little bit differently, but they do charge a facility fee for outpatient visits in the hospital. I think that their code is a little bit different, but they do charge a facility fee and a professional fee, as far as our research indicates.
Okay, well, thank you so much. Thank you, Madam Chair.
Any other questions on the GMH fees package? Senator Parkinson or Senator Atta? Okay, thank you. Thank you again. Again, we will now hear testimony on Bill 24-38 COR, authored by Senator Will Parkinson. Ask all invitees that will be testifying today on this bill to please come forward and have a seat at the table. Thank you. And we will begin with remarks from the author of the bill, Senator Will Parkinson. You have 10 minutes.
Thank you, Madam Chair. And thank you to everyone who has joined us today to participate in this public hearing. We are here to discuss Bill 24-38, legislation I introduced to require emergency healthcare facilities to provide information and access to emergency contraceptions for survivors of sexual assault. This bill is about timely, compassionate, evidence-based care. It is about meeting survivors in a moment of crisis with real medical options. Let me begin by stating something very clearly, because it is often misunderstood. This bill is not about abortion. Emergency contraception does not end the pregnancy. It prevents one from happening. Emergency contraception works by stopping or delaying ovulation. If there is no egg, there is no fertilization. And without fertilization, there is no pregnancy. That is how it works. This is prevention, not termination. That distinction matters, and it must ground our conversation today. Guam has the second highest rate of rape per capita in the United States. In 2020, 75% of reported survivors were minors. These are not distant statistics. These are young women and girls in our schools, in our homes, and in our community. They deserve access to all medical tools available to protect their futures. They deserve the right to make informed decisions about their care in the hours and days after traumatic events. This is not the first time I've introduced this legislation. I introduced a version of this bill in the 37th Guam legislature because the need for it has been clear for years. Survivors have waited long enough for a system that treats their care as urgent, consistent, and informed by science. I reintroduced it this term because I remain committed to ensuring basic standard of care is law. Timing is essential. Emergency contraception is most effective when taken as soon as possible. The American College of Obstetricians and Gynecologists states that while emergency contraception can work up to 5 days after unprotected sex, it is most effective within the first 12 to 24 hours. Every hour matters. Emergency rooms are often where many survivors turn first. It is where injuries are treated, evidence is collected, and recovery begins. According to national standards of care, including those from the the U.S. Department of Justice, survivors are encouraged to seek medical attention as soon as possible, ideally within 48 to 72 hours. This is the same time window when emergency contraception is most likely to be effective. If the option is not presented during that visit, it may be lost entirely. The bill created a new chapter in Guam law that set a clear standard of care. First, it requires that any licensed emergency healthcare facility provide emergency care to a survivor of sexual assault. That includes providing medically and factually accurate oral and written information about emergency contraception and sexually transmitted diseases. Second, the facility must inform each survivor of their option to take emergency contraception. Third, if the survivor requests it, the facility must provide it unless it is medically unsafe to do so. If the contraception is in pill form, the patient must receive both the initial dose and the follow-up dose. In addition, the bill requires that emergency facilities have written policies and procedures to ensure their personnel are properly trained. Staff must be prepared to give accurate, unbiased, and compassionate information. It also tasks the Department of Public Health and Social Services, in collaboration with the Bureau of Women's Affairs, the Guam Sexual Assault Response Team, and the Guam Coalition Against Sexual Assault and Family Violence, to produce culturally appropriate and easy to understand written information for survivors. That material must explain how emergency contraception works, how effective it is, where it can be obtained, and what treatment options are available for sexually transmitted diseases. I also want to note 22 states and the District of Columbia already require emergency rooms to offer information about or access to emergency contraception for survivors of rape. National organizations including the American Medical Association, the American Public Health Association, and the American College of Obstetricians and Gynecologists recommend it as standard medical care. This bill is not controversial. It is responsible. It ensures that a survivor does not leave an emergency room without being told that she has options. It ensures that we treat survivors with dignity, with urgency, and with access to real medical care. Thank you, Madam Chair, and I look forward to hearing testimony on this bill today. Thank you very much.
Thank you, Senator Parkinson. We will now proceed with testimony on Bill 2438 COR. As you provide your comments, please speak closely into the microphone, state your name and the organization or government agency that you are representing. And we will start with, to my right.
Hi, my name is Christine Zucchero. I'm the Assistant Administrator of Nursing Services at GMHA. I am here to answer any questions that may be directed to GMHA. Thank you.
Good afternoon. Thank you for letting me speak today. I'm here on behalf of GMHA as the Chief Medical Officer. I don't have a position per se, but I wanted to give information about what happens with patients that are the victims of sexual assault that come to the ER. They are treated for their medical and their injuries. The doctors will then refer them to social services like Healing Hearts to talk about counseling. The doctors also counsel them about their options. As you mentioned before, the contraception is important to take as soon as possible. Within 3 days is when it's most effective. After 3 days, it's not as effective. On Guam, there are 2 contraceptive medications you can take. It's called My Way and Plan B. Both are over-the-counter prescriptions, meaning that you do not need a prescription to go and get it. You can go to the pharmacy, request it, pay for it, and they'll give it to you. The pills are not physically in the hospital, meaning that we cannot give the pills to the patients. We can give prescriptions to the patients, and then they then have to go to the pharmacies to then fill the prescription. Some of the physicians do give counseling because of their nature of training. They're comfortable. Some physicians stabilize the patient, treat their injuries, and then refer them to the Healing Arts for further care. Again, I'm not speaking for or against the bill. I'm simply explaining the processes that happen at GMH when patients come in with sexual assaults. But any questions that the members may have as far as the medical aspect of it, I'm happy to answer. Thank you so much.
Thank you. Ms. Flores.
Hafaday, Senator Bree, and committee members. My name is Jane Flores. I'm the Director of the Bureau of Women's Affairs, and I am here to state that the Bureau of Women's Affairs is in strong support of Bill number 2438 relative to emergency contraception for survivors of rape. This bill, authored by Senator Will Parkinson, will codify the ability of a victim of sexual assault to have access to emergency contraception if she so chooses. The act of offering emergency contraception medication to female victims of sexual assault is already in practice at the Guam Regional Medical City and Healing Hearts Crisis Center, Guam's Rape Crisis Center being run under the Guam Behavioral Health and Wellness Center. And unfortunately, as Dr. Niami just pointed out, GMH does counsel patients, but they don't have the pill available in the ER. Is that correct, doctor?
That is correct. We don't have the physical pill. We give a prescription to the patients should there be a need or request, but the physical pill is not available in the hospital. They would have to go to a pharmacy to get that pill.
And usually, from my understanding, working closely with Healing Hearts, as I do, because we give them some grant money through the Guam's Sexual Assault and Abuse Resource Center Association, Healing Hearts does offer this medication to the patient free of charge because it is over-the-counter medication. Following the U.S. Supreme Court's decision in June 2022 that there is no constitutional right to abortion, women's reproductive rights have been seriously eroded in more than 1/3 of the jurisdictions in the United States. The Bureau of Women's Affairs thanks Senator Parkinson for this legislation and fully supports his efforts to protect a victim's choice to prevent an unwanted pregnancy that might result from having been violated in such a horrific and very personal way. The BWA strongly notes that the emergency contraception, which the bill defines as one or more prescription drugs to prevent pregnancy used separately or in combination, administered to or self-administered by a patient within a medically recommended time after sexual intercourse, dispensed for that purpose in accordance with medical professional standards of practice and determined to be safe by the United States Food and Drug Administration, is just that, contraception. It prevents pregnancy. It is in no way, shape, or form an abortion drug. One form of this contraceptive medication, or two forms, are known as commercially as Plan B or My Way, and they're available as over-the-counter non-prescription drugs. Therefore, we recommend that over-the-counter or be inserted before the phrase prescription drugs in this definition. We also have several other suggestions with regard to this legislation. We recommend that Guam Behavioral Health and Wellness Center, the department under which Guam's only rape crisis center is established, should be included after emergency health care facility throughout the bill. We also think that it may be unnecessary to include Section 4, written information relative to emergency contraception for sexual assault victims, in this legislation. This section requires the Director of the Department of Public Health and Social Services, in collaboration with several agencies, including the Bureau of Women's Affairs, to develop, prepare, and produce written information relating to emergency contraception for the prevention of pregnancy in sexual assault victims and sexually transmitted diseases. The information about emergency contraception is already provided to victims at Healing Hearts and at GRMC and at GMH when they dispense the prescription by the healthcare professionals when they treat victims of sexual assault. Also, emergency contraception does not prevent sexually transmitted diseases, so this phrase might have to be reworded. If the intention of this section is to explain this medical information in layman's terms to victims of sexual assault and the general public, then perhaps that should be highlighted as the purpose of producing this information for general public consumption. Again, we thank Senator Parkinson for what we believe is a necessary effort to set into law the right of a female sexual assault victim to choose access to emergency contraception to prevent pregnancy. While the Bureau of Women's Affairs wishes this legislation was not necessary, unfortunately, given the current climate of attacks on women's reproductive rights in our country, it is very necessary. Sijus Masi for the opportunity to provide this testimony in strong support of Bill 2438 with the changes we have suggested.
Thank you, Ms. Flores. We will now take questions from the panel. Senator Parkinson, you can begin.
Oh, I'll pass for now, man. I'll save my questions for close.
Okay. Senator Terlahi? Ms. Ariola, would you like to testify on this bill? We have your written testimony. You would just want to submit your written testimony? Okay.
Thank you, Madam Chair. So, according to Public Health's written testimony, it says, DPHSS is restricted from publicly testifying. Please see attached Congressional Research Service report regarding Title 10 provisions. It states funds cannot be spent on any activity, including the publication or distribution of literature that in any way tends to promote public support or opposition to any legislative proposal or candidate for public office. And that's because we receive Title 10 federal grant funds for the MCH and family planning programs. I guess I'm just confused because the public health testifies on many bills, but you're saying only certain bills you're prohibited from testifying on? Or now all bills?
In the first line of her testimony, it says, is restricted from providing public support or opposition to this bill, which is one of the mandatory requirements of Title 10 Family Planning Program.
All right, I don't think it's clear, but all right. Then I guess Bureau of Women's Affairs, Ms. Flores, when you said perhaps we should delete Section 4, to me, Section 4 was the whole gist of the bill, that they wanted people to have this information in writing, but you're saying this information is already given, and then provision 2, Section 2 is the provision of emergency care to sexual assault victims. You're saying this is also already being done, isn't it?
Healing Hearts does give out, from my understanding, they do give out the emergency contraception if it is requested, and they also tell the victim exactly what, and there's literature. It's like when you get any kind of prescription, you get literature that tells you all about it, and so unfortunately at GMH, they don't usually, because GMH emergency room is not really a private place. When they have sexual assault victims, to my understanding, unless they are medically unable to leave the hospital, they do send them over to Healing Hearts, where there's a much more private area to have the exam and be counseled and get the medication.
I guess, okay, let me rephrase my question. So if Section 4 is kind of duplicative of what's existing practice, isn't Section 2 also duplicative of existing practice when GMH is testifying that they already counsel people who come to GMH, GRMC is counseling people?
It is, but it's important to codify this, to put it into law, only because, as I mentioned in my testimony, in more than 1/3 of the jurisdictions in the United States, women's reproductive rights are being seriously eroded, and we just want this to always be available to women if they so choose to have emergency contraception.
Dr. Niami, as the medical director of GMH, if we did not have this statute, you have testified that doctors are already informing sexual assault victims that have code to GMH of the option of emergency contraception. Is that correct?
Currently, doctors are treating patients and stabilizing them for their medical injuries. They're also discussing, not all doctors, some doctors are given counseling and then referring the patients to Healing Hearts to have an in-depth counseling and also literature and also other services that's available. So yes, if we're not doing the counseling directly, we are then sending a patient for referral to Healing Hearts where they are further counseled.
All right, and you're saying that's being done as a standard of care?
Currently, yes, that's the standard of care within GMH. Patients come in for sexual assault victims. We stabilize them, we treat them, we then counsel them, and then we refer them to Healing Hearts to have further counseling and literature, and even possibly the Plan B medication given to them. We do not actually give the pill. We give a prescription for the pill if necessary. They meet the criteria, and then Healing Hearts and the pharmacies will do the rest.
All right, so if the law changes and now doctors are mandated to give information about emergency contraception, and they're mandated to orally inform each sexual assault victim of her option to be provided emergency contraception, and doctors are mandated to provide emergency contraception upon her request. Is GMH able to comply with this?
Currently, because the physical pill is not within the hospital, we would have to make changes to acquire the physical pill in order to give it to the patients before they left the ER. At this time, if this bill becomes a law, we would be not in compliance with the law.
So if it says to provide emergency contraception, giving a prescription is not adequate to meet that standard?
I think it depends on how one reads the
Yeah,
law
that's why
and
I'm
the bill.
asking you.
The way it reads, it says prescription drug. It doesn't say prescription. Because it says prescription drug, I feel that if this bill would become law, we would not be in compliance. If it said prescription and left out the word drug, I believe that we would not be in compliance.
Actually, on page 3, it does require that you shall include the initial dose, so you do have to have the pills. So is GMH able to do that?
At this time, I cannot answer that question, ma'am. I'm happy to do some research and get back to you, however.
Mr. Caro, is there any reason GMH would not be able to do that?
From my understanding, we just have to go through procurement to get the medications to purchase and obtain the medication to be in our stock.
All right. And so the question of what you have in stock and what you don't, that's who makes those decisions? Is that currently a board decision, or that's a medical director's decision?
We have a committee that regulates what's formulary and non-formulary for our medication.
So what is this?
I don't have the information if this is formulary. My understanding, I don't think it's one of our formulary medications, just because it's not probably required to stabilize the patient in an emergency setting, but still can be given in an outpatient setting to be within standard of care.
All right, thank you. And
If I may, madam,
yes.
Any medication that is new that would like to be introduced to the formulary has to go through a committee called Pharmacy and Therapeutics. That committee has to do an assessment of the need for the medication, the cost of medication, the availability of the medication, and the benefit of the medication. Once that assessment is done and the Pharmacy and Therapeutics Committee feel that this medication is overall beneficial, they would then vote on it. It would then be moved to several committees until it's voted upon, and at that point, it can become a formulary. Right now, this medication is a preventative medication in the nature that it does not stop pregnancy, but it prevents pregnancy. For that reason, it is a medication that at this time, because it's available at the pharmacies, a prescription can be given and the patients can go to the pharmacy and then pick it up. Or they can go to the pharmacy without a prescription and get the medication. Or they can go to Healing Hearts as a referral and get the medication. But if we're interested in introducing it to the formulary for the hospital, that is possible, yes, ma'am. But right now, I can't answer the question of whether or not we can, because it is a committee discussion.
And do you believe that physicians at GMH or anywhere are currently mandated to refer sexual assault victims to Healing Hearts?
It's not a mandate. However, it is something that we practice on a daily basis. All the physicians that I have work in the ER, as soon as they learn that these patients are victims of sexual abuse, they get referred automatically to Healing Hearts.
So do you think we run the risk of, if we don't mandate it, that they're not going to do that? I guess that's really the debate here, because you're saying you're already doing all of these things. The prescription's already available from the doctors directly, or your referrals to Healing Hearts are already happening. But there's some testimony that we may be in danger that future GMH policy or future physicians or somebody else is going to stop you physicians from referring to Healing Hearts or giving the correct information regarding what's available to these persons, sexual assault victims, or giving them contraception if they request it.
I think these are questions that I think require thought. I just don't have the answers to these questions, because right now we have a system in place that works for us. I'm here mainly to give responses to questions that the body may have in regards to the practice of how patients are treated once they come in with sexual assault victims. But I don't know if passing this law will change how doctors prescribe or how doctors treat the patients. That is something that I cannot right now foresee or answer. I apologize.
All right, thank you. And there's, okay, so just, I guess I agree with Women's Affairs that if Healing Hearts is already the expert on the material, they've already produced these things in written format, and we are already making referrals, perhaps we don't need new information to be written with all these other entities, including public health. Is public health prohibited from collaborating to produce the written information related to this? You're not prohibited from doing that? You're only prohibited from talking about it? I guess, yeah, Jane, would you say that we need any more written information, or we leave that to Healing Hearts, and that Healing Hearts be mandated to provide that information to all treating physicians?
I do know that Healing Hearts does provide it.
That's what I'm saying.
Just to defend public health's position, I know that a lot of our grants with the Coalition Against Sexual Assault and Family Violence, that's why they're not here, is because they are federally funded, and if you are federally funded, oftentimes you are not allowed to take a position on any bill because of your federal funding.
Yeah, but my question was on any bill? Or on any bill?
Or any bill that...
What kinds of bills? That's what I want, is what is that criteria?
That deals with your grant. And in this case, it's family planning, so I didn't make the rules, so I
know,
don't
but it just says we're restricted from publicly testifying, period. It doesn't say in regards to these topics or those topics, and we have seen them testify.
I'm not
in
federally
many
funded, so I can...
All right, so, but my question was, if Healing Hearts is already producing this information, dispersing this information, and they are recognized in our community as adequate experts in this information.
That's why I said we may not need Section 4. But I think we do need to codify the ability of doctors to be able to offer emergency contraception. Just because, given the climate surrounding women's reproductive rights in this country at this time, it's a preventative measure to be able to codify it into law, so that in the future, legislatures or some state or says we're not going to we don't like the idea of contraception. We're not going to allow people to offer emergency contraception.
They would repeal this law, right? Right now, there's nothing prohibiting it.
But if you don't have the law, it's a lot easier.
No,
you have to go
they would have to pass a law, right?
Yeah.
Same.
Yeah.
All right. This is Masi to all of you testifying. Thank you, Madam Chair.
Thank you, Senator Terlahi. I'd like to recognize Senator Shelley Calvo, our Majority Whip of the 30th Guam Legislature, who is with us today. Senator Taidakui.
Thank you, Madam Chair. You know, I did too have a question regarding the other clinics, because if you ask me, you know, many of the other clinic, like healthcare clinics, facilities, they are sometimes utilized when it comes to, you know, emergency, or it's someone who was sexually assaulted. The first place they can go is the nearest one, and sometimes in the South it's the clinic there. So. But the bill doesn't say that in here. You know, the bill does not clearly state with regards to other other clinics or community health centers. It just goes straight into emergency. So is this something that public health cannot, you know, avail themselves to in case somebody comes into one of their facilities at public health? I know you can't testify in favor or for or against, but you can at least ask our questions, right, Madam Chair, to at least public health is here. At least they can answer the question whether public health is able to receive anybody who's been sexually assaulted at one of their clinics. Can they answer that? Madam Director Arreola, can you come to the table and at least answer that one question? What happens?
Are you not able to, yes or no? I can read your testimony into the record if you'd like.
But it's just a question. Does your clinic, my mic keeps going on. Does the community, community center, not centers, but the healthcare centers or clinics under public health, they receive anybody that's sexually been assaulted? What happens in that situation? Are they sent to Guam Memorial? Are they sent to Healing Hearts automatically? What happens at public health?
Thank you, Senator, for your question. Senator Sabrina Salas, Teresa Arreola, the Director of Public Health and Social Services. I would please indulge all the senators, so please read my testimony that I submitted on this bill, and I kindly ask that you not put me in a position to speak of anything that's going to jeopardize our current grant for family planning. So I'm not doing this on purpose or being very, I'm not trying to be defiant. I'm just trying to protect the current grant that doesn't allow me to speak on this behalf. So I'm up here on the table because I just don't want you to think that I'm ignoring the question. I just can't answer it.
Thank you, Mrs. Arreola. Let me just go ahead and just read the testimony for our viewing audience so that they are aware of what's happening right now. This is a letter from the Department of Public Health dated May 13, 2025. Bill number 2438, enact add a new chapter 98, Title 10, Guam Code annotated, relative to emergency contraception for survivors of rape. Dear Madam Chairwoman, thank you for the invitation to provide testimony on Bill number 2438, but Department of Public Health and Social Services is restricted from providing public support or opposition to this bill, which is one of the mandatory requirements of Title 10 Family Planning Program. Bill number 2438 appears to be the reintroduction of Senator Parkinson's bill number 7837. In September 2023, DPHSS was asked to provide testimony for the initial bill. However, as the recipient of Title X federal grant funds for the MCH and family planning programs, DPHSS is restricted from publicly testifying. Please see attached Congressional Research Service report regarding Title X provisions. On the top of page 2, right column, third bullet states, funds cannot be spent on, quote, any activity including the publication or distribution of literature that in any way tends to promote public support or opposition to any legislative proposal or candidate for public office, end quote. Thank you for your understanding. Teresa C. Areola, MBA Director. And that was...
In my presence here, Senators, just so you know, you understand, I'm really here to testify on the next bill. And only because the time was set at 2 o'clock that I came at 2 o'clock. But I'm really not here to testify or speak on Bill 24.
All right, Madam Chair, I'd just like to note that, so the rule that they're citing says that they cannot do any activity that promotes public support or opposition to a legislative proposal. But I think a request for information is neither support nor opposition. It's simply information that should be available to us and to the public in making these decisions.
Yep. Also, just in the letter, she indicated that this is public testimony, so I think perhaps off record on the side, aside from in this public forum, it appears that she'd be willing to answer any questions that you have. I personally do not want to put any federal grant money, I don't want to compromise any federal grant money at this point because, as we all know, the Trump administration, there's several cuts that are pending. So I just ask if we could answer these questions offline. Yeah, please.
Okay. Well, that being said, I will because I'm very interested in this. Then I can ask Jane Flores, you receive any federal funding that you can't be here to testify in support or against? Because it's obvious, I hear that Women's Bureau does get funding.
We receive federal funding to help victims of sexual assault and family violence with services, but we don't receive any funding for medical services at all. So
you're exempt?
So I'm exempt from this bill, yes.
Well, we don't want to jeopardize that scenario. Do you know, Jane, then, if you can tell me if this Plan B medication can be picked up at any pharmacy on the island?
Yes, we actually did a survey about a year and a half ago and called pharmacies, and it is between $35 and $50 a pill.
Okay.
So,
and
or for the set of pills, I'm not quite sure how many you have to take. So.
Okay, can you get this medication without a prescription?
Absolutely.
You can, right?
Yes.
So anyone can go and get
it's
a
over
prescription.
the counter. Yes.
Okay, and if I'm not mistaken, Guam Behavioral Wellness Clinic receives funding from the Edward Byrne Grant. Are you familiar with the Edward Byrne Grant? Okay.
Yes.
Is that in jeopardy of being cut as well? Because I know that some of these funds, like the chairperson said.
Yes, it is. As a matter of fact, it is one of the grants on the list that we received from the Trump budget bill.
Is Healing Hearts also receiving this money from Edward Byrne Grant? In other words, how are they paying for this?
I believe, and I am not the expert on their funding, but I do believe that the Byrne Grant pays the SANEs, the sexual assault nurse examiners, and I think it pays for the rape kits. I'm not sure.
Well, sexual assault and rape, it's...
Sexual assault nurse examiner is when a person is sexually assaulted, they go to Healing Hearts, they will call in someone who is trained to conduct a sexual assault exam, and it's got to be either a registered nurse, a nurse practitioner, or a physician. They are specifically trained to handle this. And I'm not sure what their hourly rate is, but sometimes these exams take several hours. Mm-hmm. And so I think they are paid by the Byrne Grant, if I remember correctly.
So they would also be the one to administer any kind of, like the Plan B?
Correct, or give them a prescription if they don't have it. But I do know Healing Hearts does have the pill on hand.
Okay. So yeah, that's what I was concerned about, the Edward Byrne grant being cut as one of those federal funds that are being cut, and how it's going to, because basically when they do go to Healing Hearts, this prescription is free.
Correct.
Right? Okay. But there is the option to go to a pharmacy without a prescription in order to receive that as well. Okay.
But you would have to pay at a pharmacy. You would have
Yeah.
to go and pay. It's not a free prescription.
Okay. Well, I'm looking forward, Madam Chair, to, offline speaking with public health, because the bill does not state emergency healthcare facilities as providing community health centers or certain clinics too that provide free service. So this is something I'd like to know as well, that can be maybe incorporated later into the committee report, stating that. But other than that, that's all the questions I have for now. Thank you, Madam Chair.
Thank you, Senator Taitigui. Senator Ada? Okay. Senator Calvo?
Thank you, Madam Chair. Not really a lot of questions at the moment. I just want to thank everybody for being here and for your testimonies. As a woman, I do understand that, an extra layer of protection is always good, especially for unwanted things that takes place, on, these are challenging times for victims, right? And if you really think about it, the least thing one would want is to worry about unintended consequences. So, I really don't have anything to say. I'm just thinking about all these victims, and I think there should be a way where we can extend help to them. And I know that this bill is well intended, and this is one of those things that wants to preempt additional challenges in the life of victims, right? But at this point, I'd like to keep an open mind with regards to this bill, and no questions that I wanted to say. But thank you, Sidu Usmasi, Madam Chair.
Thank you, Senator Calvo. I did have just a couple of questions, maybe that you could answer, Jane. There was just needed clarity in the legislation because there wasn't any reference to age. And so, in your opinion, what do you believe should be the minimum age of a survivor this emergency contraception should be administered to?
I am not qualified. I would turn to Dr. Naomi for that, but I would think that if a victim is menstruating, that would make it, because especially the younger the victim, going through a pregnancy would be dangerous for a 10-year-old child, I would think. But again, I'm going to defer to Dr. Naomi.
Dr. Naomi?
So Plan B and My Way are synthetic progesterones. It's a large dose of progesterone. If you give that medication to a patient that is not a childbearing age or adolescent, there can be consequences. And so the age limit is you have to be childbearing. That is the criteria in order to meet, in order to give the medication. As far as a number, unfortunately, everyone goes through menstruation at a different age, and so it's hard to say the number, but the childbearing age is the description for the medication when you give it.
What are the stats? Does the Guam Memorial Hospital keep stats on the prescriptions for this emergency contraception? You mentioned that you don't give this medication, but you issue prescriptions. Prescriptions. Do you have stats on that?
I don't have stats as to how many prescriptions are given per population. I can give you that in the year 2025, there were 9 patients that were sexual assault victims. Of that, 5 were pediatrics, and then 5 were adults. Pediatrics means less than 18 years of age, and then adults means above 18 years of age. And then in 2024, we had 7 patients that were sexual assault victims. Of that, there were 4 pediatric patients. Again, pediatrics means less than 18 years of age. and then 3 were adults. Again, that means above 18 years of age. And then in 2023, we had 3 patients that were sexual assault victims.
You said below 18?
For pediatrics,
Yes.
is below 18. For adults, is above 18. So those numbers are for 2025, total of 9 patients. Of that, 5 were pediatrics. And then, I'm sorry, I apologize. 4 were pediatrics, and then 5 were adults. I apologize.
What is the youngest age in the demographic?
I'm so sorry, Madam Rights Woman, I don't have that information. It's stratified into pediatrics and adults, but she may have that information.
I'm sorry, Ms. Flores?
I'm actually asking Shirley Untalan from Healing Hearts right now, what's the youngest age they've administered Plan B to? She can't give that answer off the top of her head. I apologize. But I can get that information for you. I do want to note, though, that the GMH statistics that we get from them every year with regard to sexual assault and family violence, with regard to the sexual assaults, in the last 6 years, the average has been around 65 to 70% of the victims of criminal sexual conduct. Now, criminal sexual conduct runs the gamut from rape to touching, but most of the victims are under the age of 18, most of them. So it is important to protect them in any way, shape, or form that we possibly can.
Thank you. Senator Parkinson?
Thank you, Madam Chair. I don't really have too many questions, just really some statements. You know, when I think about the necessity for legislation like this, I think about how this works for the end user, for the people who are actually going through this in real time. And one of the things that really sticks out to me in this is the notion that time matters, the hours matter. And when I think about time mattering, I look at some of the roadblocks to women getting this medication. One is ambiguity in the law. There is no standardized best practices codified into Guam law. Now we do those best practices, and God bless those organizations that have figured out what these best practices are. But my concern is if it's not codified, it remains ambiguous. Ma'am?
Senator, with regard to that, what you just said about the end user, one of the issues that I would see with someone is if GMH is just writing them a prescription and they have to take it to a pharmacy and they're an indigent person, they have to find the money to pay for this drug. Whereas if you go to Healing Hearts, it's free, or possibly at GMH it should be free if they get it, they go through their drug committee or whatever to. So there's a consideration. That's one of the barriers, is that if you have to pay for the drug, then and it's not available for free, and you can't come up with the money, what do? Then you have to possibly get pregnant from your rapist.
I understand. Thank you so much. And that's something I wanted to talk about too, is that, you know, why do we codify these things? Is because part of the reason we codify good practices is because, you know, good practices have to start somewhere. I think about way, way, way back in the history of humanity. Once upon a time, it was not codified that we would have things like fire departments. You know, people back then, they probably had best practices. A house would go on fire and they'd go out and put some water on it. And eventually, as these things happened more and more often, we decided in the wisdom of the masses that it would be better to codify some of these good things that we do for society. Now, we have organizations that have found the best practices for how to interact and interface and help victims in this very, very traumatic time. And we need to start to standardize those things so that when I'm no longer sitting in this chair and none of us are sitting in this chair and it's a whole new generation of people, the practices that we talked about today will still be in the law, in the books long after we've all gone. We do not write legislation for times we are here, times we are actively in these chairs. We write them for the times that we are no longer here. And I want to make sure that when I leave this office, that there are best practices in place to make sure that survivors are taken care of. Time matters. We need to clear up this ambiguity by codifying these laws. We need to make sure that these medicines can be received directly by the people who need it. I think it's a real disservice that the hospital cannot just give this medication directly to people who need it. And I think that's something that needs to be changed. Because I agree with Ms. Flores about how we're looking at this from the end user. If I'm going through a real traumatic time, I'm not in my tip-top shape physically, mentally, spiritually, and I'm being told, bombarded with all these information while I'm probably going through the worst day of my life by far, and I have to go and get a prescription. I might have to go to Healing Hearts. I might not have the money to do this. I might not even have a ride. We really underestimate the kind of financial struggle that people are going through, and and them leaving the hospital that day or the clinic or whatever point of first contact we reach them at, that might be the one and only chance we have to prevent a child coming into this world that is not in the right circumstances, not under the best circumstances for the woman, and not in the best circumstances for the child that could come from it, and not in the best circumstances of the state, who may have to pick up the slack when situations like these fall through the cracks. And I say that we should standardize these laws. We should make sure that parts of points first contact reach it. Like, what we're doing is we're not trying to reinvent the wheel. There is proof of concept. There are 22 states that have already done this. So we're not asking for anything that no other state has gotten. We're asking to join the reasonable on how to get ahead of this problem. I want to reiterate that this is not ending pregnancies. This is preventing them. This is emergency contraception. The fact that it doesn't end pregnancies and it is not considered an emergency, that they be carried at hospitals, is shocking to me. And so I would ask my colleagues to please support this legislation. I am open to any and all amendments to this bill. For me, what is important is that people get the medicine that they need, and whatever amendments we need to add to this bill to make sure they get that, if we want to expand it beyond emergency rooms to clinics, I am 110% on board with that, whatever it takes to get it. Just very briefly, ma'am, I'd like to read out some numbers, referrals from Healing Hearts, just so people can get the scope of the problem we're dealing with. In 2020, there was 55 referrals. In 2021, there was 68. In 2022, there was 87. In 2023, there was 71. In 2024, there was 75. I believe in 2025, we're up to 9 right now. And the majority of these people are minors. So when we step in to help them and prevent these unwanted pregnancies from happening, we are not just helping people in their time of trauma, we're saving futures that would otherwise be derailed by it. So thank you very much, ma'am, for this and for hearing this bill. And I once again ask my colleagues to please support this legislation. Thank you very much.
Thank you, Senator Parkinson, and I'll also just add to that that those are just the cases that are reported. You can only imagine the ones that are not being reported. Senator Tydekwe, you did have one more comment you wanted to make?
Yes, thank you, Madam Chair. It's just for the record, when we go into the market meeting on this legislation, is to ensure that we do our part in finding out if we codify this legislation that we may lose out on any federal funding that's provided. That it happened in the past before when some legislation that used to be funded by federal grants, and then when we codified it, we lost any opportunity to have federal funding. So if the committee can look into that, I don't want to lose any opportunities that way. Thank you.
Thank you. I appreciate that, Senator Tydekwe, and thank you, Senator Parkinson. We are now concluding testimony on Bill 24. Thank you, Ms. Flores. Thank you, Dr. Naomi. Thank you, Christine. We are now going to accept testimony on Bill 76, introduced by Speaker Frank Blas Jr., an act relative to emergency care immunity from liability. At this time, I ask those who've signed up to testify to please take a seat at the table. Speaker Blas is currently off island, but has provided written comments, which I will read into the record on his behalf. Quote, thank you, Madam Chair, for holding this hearing that addresses the immunity from liability for persons who provide emergency medical care utilizing the training they received and the equipment available to them. I apologize for my absence as I am attending a Pacific Regional Board meeting off island. Bill 7638 COR addresses a liability concern that hangs over the heads of individuals who rely on their training and experience to provide emergency medical care when it is needed most. While there exist statutes that protect medical professionals in the performance of their duties in a clinic or hospital, the protection from liability in events outside of these settings, like accident scenes or while transporting an individual needing further emergency medical attention, currently do not have the same protections. This bill addresses that. Again, thank you for hearing this bill in my absence, and I look forward to working with you and the committee on any suggestions provided through testimony to work on and resolve the liability concern addressed with this bill. Sidzo Usmaasi, end quote. That was opening comments from Speaker Frank Blas Jr., the author of Bill 7638. We will now proceed to hear a public testimony from those of you seated at the table. And again, if you could speak closely into the microphone, state your name and your title. Starting to my right.
Thank you. Thank you, Chairwoman Sabrina Salas Matanane. My name is Teresa Areola, the Director of Public Health and Social Services. I'm here to testify on behalf of Bill 76-38 COR. Hafaday Chairwoman Sabrina Salas Matanane and members of the 38th Guam Legislature. Thank you for the opportunity to provide testimony on Bill 76-38, an act to add a new subsection 84-124 to Chapter 84, Title 10, Guam Code Annotated, relative to emergency care immunity from liability, introduced by the good Speaker Frank Blas Jr. The Department of Public Health and Social Services, the Health Professional Licensing Office, Emergency Medical Services Office of the Division of Public Health believes the intent of the proposed legislation was created to protect our island's emergency medical services, EMS, and health providers. DPHSS believes that Bill 76-38 aims to provide immunity from liability for individuals who provide emergency care. This legislation is crucial for the well-being and safety of our community. In emergency situations, every second counts. The willingness of bystanders to step in and provide immediate assistance, even before professional help arrives, can be the difference between life and death or the severity of an injury. However, the fear of potential legal repercussions can create a chilling effect, causing individuals to hesitate or refrain from offering help altogether. This proposed act seeks to protect those who act in good faith and with reasonable care to assist others in distress. It acknowledges the moral imperative to help our fellow citizens and removes a significant barrier that might prevent well-intentioned individuals from doing so. It is not intended to shield those who act recklessly or with malice intent, but rather to provide a safety net for those who step forward to offer aid during critical moments. We believe the bill was created with good intentions. However, there are areas that require some clarifications. Number one, potential for decline in the standard of care. While the proposed act includes the phrase acting in good faith, DPHSS is concerned that it may inadvertently lower the standard of care provided by EMS personnel. The fear of liability, while sometimes seen as a burden, also serves as a crucial motivator for maintaining high professional standards and ensuring that all possible measures are taken to provide the best possible care in emergency situations. Removing this potential liability, even with a good faith clause, could lead to complacency or reduction in diligence. Two, the difficulty in proving bad faith. The legislation hinders on the concept of good faith. However, bad faith can be exceptionally difficult to prove in court of law. This could leave patients who have been suffering harm due to negligence with limited or no recourse, even in cases where the actions of an EMS provider fall demonstratingly below acceptable standards. DPHSS Medical Director Dr. Robert Leon Guerrero provides his input and suggests clarity on whom would be that entity that will determine or define that the act was done in good faith. Three, the lack of transparency and accountability. This blanket immunity could create a system where errors or substandard care are not properly investigated or addressed. This lack of accountability may be seen as failure to protect patients, but also hinders the ability of the EMS system to continuously improve its practices. Another concern raised by Dr. Leon Guerrero for the layperson who rendered emergency care, the following questions need to be addressed and clarified. Who will determine that the layperson has absence of gross negligence? Two, who will be liable if the rendered emergency obstetrical care resulted in birth trauma which caused the child to be disabled? Would that be the government of Guam? We know that care, pending on the severity of the disability, can be a financial burden to the family. As stipulated in 7 GCA Chapter 11, subsection 11308, action to recover damages for injuries, an action to recover damages for injuries to the person arising from any medical, surgical, or dental treatment, omission, or operation shall be commenced with 1 year from the date when the injury is first discovered, provided that such action shall be commenced within 3 years from the date of treatment, omission, or operation upon which the action is based. And thirdly, does the EMS Commission, which is in place today, have the authority to handle complaints against the layperson? Fourth, alternative solutions proposed. DPHSS believes there are alternative ways to support EMS and healthcare providers without compromising patient safety. These include providing adequate funding for training and equipment, implementing clear protocols and guidelines, offering robust continuing education programs, ensuring access to mental health support for EMS personnel and healthcare providers who experience traumatic events, exploring insurance options such as liability insurance that protect EMS providers, healthcare professionals, and patients, and strengthening oversight and purview processes for EMS procedures. Unfortunately, for the average layperson, the above safety nets are not readily available. Current Guam law already defines who will cover any potential damages when transporting a patient, as defined in 10 GCA Chapter 84, Emergency Medical Services, subsection 84110E. Ambulances, private companies offering ambulance services, and private non-emergent transport vehicles shall be operated in Guam with insurance coverage issued by an insurance company licensed to do business on Guam for each and every ambulance, private non-emergent transport vehicle, and private ambulance service owned or operated by or for the licensee. Additionally, current Guam law also allows for a person who is providing emergency care to not be liable for any civil damages, as defined in 20 GCA Chapter 2, subsection 2104, or more commonly known as the Good Samaritan Law, which states any person who renders emergency care or assistance without compensation at the place of an emergency or accident shall not be liable for any civil damages resulting his acts or omissions expected for such damages as may result from his gross negligent or wanton omissions. In closing, DPHSS recognizes and appreciates the critical role that EMS providers and healthcare professionals play in our community. We urge the committee to provide further clarity as previously presented in the hopes that it will provide continuous support to EMS providers and healthcare professionals while also safeguarding the rights and well-being of the people who receive emergency services. Respectfully submitted by myself. Thank you.
Hafadena, good afternoon, Senator Salas, Matanane, members of the 38th Guam Legislature. I'm Joey Nicholas, the Deputy Fire Chief for Guam Fire Department, and I'm actually here to read into record the testimony of Fire Chief Darren Burrier of the Guam Fire Department, so I'll begin. Buenos and Hafaday Senators. The Guam Fire Department provides the following testimony on Bill number 76-38. The bill seems to mirror the intent of the Good Samaritan Law, which provides certain legal protection for individuals who assist in emergency situations. Guam Fire Department emergency medical technicians on and off duty are already held to standard operating procedures and EMS protocols created in conjunction with the EMS medical director and standards created by the United States Department of Transportation. Section A, legislation regarding this matter already exists in Guam law, and Section A of the bill may be redundant. 20 GCA Chapter 2, subsection 2104, persons rendering emergency assistance exempt from civil liability. Any person who renders emergency care or assistance without compensation at the place or an emergency or accident shall not be liable for any civil damages resulting his acts or omissions, except for such damages as may result from his gross negligence or wanton omissions. Section B, Guam EMS protocols outline actions to be taken by the EMT for obstetrical emergencies. Section C, Guam Fire Department personnel does not administer emergency care or direction over the phone or other forms of communication. 911 emergency medical dispatch personnel can give pre-arrival instructions to a caller or assist with CPR instruction over the phone. E911 dispatchers also have their policies and procedures in place, as well as local law 10 GCA Chapter 84, subsection 121. Section D, cardiopulmonary resuscitation is a certification needed to become an EMT. The CPR certification must also be maintained for as long as a firefighter maintains the EMT certification. Guam EMS protocols also outline actions to be taken by the EMT for the administration of CPR. Should the EMT feel that resuscitative measures be withheld, it is done based on protocols and immediate medical direction. In conclusion, the Guam Fire Department EMTs are already protected on or off duty by local law, SOPs, and EMS protocols. Should a GFD EMT withhold any type of care, it is done so in good faith based on certifications, training, protocols, and medical direction. If the patient or family members decide to pursue litigation, it is their burden to prove gross negligence and wanton omissions. 20 GCA Chapter 2, subsection 2104 protects the layperson for any actions taken during an emergency scene, and subsection 2105 protects the medical professional. Considering these situations are covered by local law, we recommend that the intent be clarified to ensure Bill 76, if passed, would not overlap or conflict with the current Good Samaritan law. Respectfully, Darren D. Barrier, Fire Chief, Guam Fire Department. From this point on, Senators, if you should have any questions for me, I'll be answering the questions on my behalf as a Deputy Fire Chief.
Thank you, Chief Nicholas and Mrs. Areola. We'll now take questions from my colleagues, beginning with Senator Terlahi.
Madam Chair, and thank you both for your testimony. It's very refreshing to see that the testimony, they are consistent with each other and that they are actually very good. I am glad that you pointed out that we already have an existing Good Samaritan law for those who non-trained professionals or those who are off duty or all of that, and that we have very high standards that we expect from those who are our professionals, that they are going to be acting according to the standards that are set and that they have been certified to perform. So, but I'm very happy that the testimony is consistent in that way. I very much appreciate as well Public Health's testimony on alternative solutions. I think we can always do these things and to make our programs where we're talking about matters of life and death, that we are always reviewing these policies, making sure that they're the best for our personnel. But we have people in place in these entities to do that, to set those standards, to improve those standards, to follow national trends and changing those standards and training our people. So I'm very happy for the also recommendations and solutions that have been proposed. So parts A and C, yeah, maybe even D. The one I'm a little bit concerned about in the bill is B, because B seems not to be talking about those who are, it's setting a standard of care for emergency obstetrical care. And I'm kind of bummed that GMH left, because I'm wondering, I thought that they would be here to testify on this provision as well. If this, I know that this is codified in the EMS chapter, but I'm wondering if this on its own would apply to the doctors who come, who come to GMH. For for the patients, who come there for OB assistants who have not been previously cared for by any doctor, and this pretty much removes all liability in the absence of gross negligence. I'm not sure about that one. That one I would need a whole other public hearing if that's going to act in that way. But again, thank you so much for your testimony. Thank you, Madam Chair.
Thank you, Senator Terlahi, and I can also speak with the author of this bill to see how we can make that more clear. Senator Taitigui.
Thank you, Madam Chair. I too am happy to see that these testimonies are very similar, so it makes it easier to, to make a decision on whether it's needed or not. You know, I too looked at several other states, California, Florida, I looked at New York and Texas, and they too have similar situations, like California provides immunity for emergency medical aid and AED use, but assistance must be given without expectations of compensation. You know, it's basically Good Samaritan law, you know, that they have in Florida covers both the layperson and healthcare providers and Good Samaritan. So I think what the Guam's is existing Good Samaritan protections, but they were more limited in scope. And previous laws exempt individuals from liability when rendering emergency assistance, but they do not explicitly cover, I'm drawing, specifically cover EMT, CPR trained individuals or emergency obstacle care. This bill clarifies and expands those protections, and I think that's what the good speaker was trying to do, expand it, but based on your testimony, it's really not needed. And I'm afraid that if we codify something like this into law, then there's that other law and then it becomes two laws. Which one do we follow, or which one makes sense? And then, so it's called a loophole. And when any judge looks at anything, they'll say, okay, which one do we follow? And they're not sure. So other than that, I appreciate you being here today to bring your testimonies forward and clarifying the law. So other than that, thank you, Madam Chair.
Thank you, Senator Taidakwe, and thank you to Chief Joey and Mrs. Areola for being here and providing your testimony. That concludes our hearing on Bill 76. And again, thank you to everybody that provided testimony on Bill 76, Bill 24, the Guam Memorial Hospital's documents 38 GL 250442 and 38 GL 250443. Your testimony, whether in support, opposition, or offering constructive feedback, is invaluable in shaping the decisions that we make as policymakers. And again, that concludes today's public hearing. It is now 3:40 in the afternoon. We are adjourned. Sizo Usmasi.